Denosumab is a lab-created monoclonal antibody which targets rank ligand and is a relatively new therapy in the anti-osteoporosis arsenal. Rank ligand is a signaling molecule that is secreted by osteoblasts. So rank ligand acts on pre-osteoclasts, and here I've used macrophages to illustrate, making them group together to form one giant multi-nucleated bone-dissolving osteoclast. The denosumab antibodies bind to rank ligand and stop them from triggering the pre-osteoclasts, and this way inhibits the formation of osteoclasts. It is given as a subcut injection once every 6 months, and similar to bisphosphonates, can be given for 5 to 6 years. It is a potent anti-resorptive, and studies have shown that it increases bone mineral density across different sites more than bisphosphonates. Another advantage denosumab has over bisphosphonates is in chronic kidney disease, as unlike bisphosphonates, denosumab is not cleared renally, so can be used in stage 4 and 5 CKD. With regards to adverse effects, there seems to be conflicting information as to whether the incidence of atypical fracture and osteonecrosis of the jaw, ONJ, is any better than bisphosphonates or not. Some say yes, and some say it's about the same. It's probably a bit too early to say either way for now. Here is a chart showing collated data from 3 landmark studies, that is Freedom, Flex, and Horizon, which marks bone mineral density change over 10 years for denosumab, zoledronic acid, and alendronic acid. And here it indicates that whilst bone mineral density increases for the first 3 years or so for the bisphosphonates, afterwards there isn't much further increase. Instead, there is a leveling out effect. However, in contrast, the bone mineral density continues to increase year after year for denosumab, so it's not really clear why denosumab is able to do this but not bisphosphonates. So whilst increasing bone mineral density is generally equated with reduced fracture risk, and it is compelling to think that this is not necessarily always the case, and reduction of fracture risk should be assessed separately for completeness. So whilst the increased bone mineral density gains achieved with denosumab seems great, however, there is a very important caution with denosumab, which is that once you stop administering it or miss a dose, there is a profound rebound effect phenomenon where there is accelerated loss of bone density and a rapid return to baseline, plus the occurrence of multiple vertebral fractures is high. And then on top of that, the rebound effect seems to be more profound the longer a patient is on denosumab. In this case study, a female patient in her mid-60s was on denosumab for 9 years. And only within 6 months of stopping, she suffered multiple vertebral fractures. And within 2 years, her BMD levels were back to baseline. But I do also want to point out that in this same chart, it does show that whilst she was on denosumab, her BMD levels did indeed continue to increase right up until she stopped it. It was just that these effects pretty much vanished as soon as denosumab was stopped. In addition, on stopping denosumab, an increase in levels of bone resorption markers is observed, suggesting that stopping denosumab causes a hyperresorptive state. So actually, return to bone mineral density baseline is seen in other anti-osteoporosis medications, for example, teriparatide and romosozumab, but they don't cause this hyperresorptive state with rebound vertebral fractures. So it is not completely clear why the hyperresorptive state happens. It is speculated that it may be due to an accumulation of pre-osteoclasts during the denosumab treatment, and then when denosumab is stopped, they all become activated, causing a hyperresorptive state. So this theory may also explain why the rebound effect is more pronounced the longer the patient is on denosumab. Rapid return to BMD baseline does not occur with bisphosphonates because they are absorbed into the bone. Their anti-resorptive effects persists for months after they are discontinued. The rebound effect can be counteracted by switching to a bisphosphonate on the discontinuation of denosumab, and the bisphosphonate requirement is mandatory. Not only does the bisphosphonate prevent the rebound fractures, it also helps maintain some of the BMD gains, at least in part, so that it doesn't drop back as quickly. With regards to which bisphosphonate to use, for patients who have been on denosumab for several years, zoledronic acid would be a better option because the rebound effects are more profound then. But for patients who have been on denosumab for shorter periods of time, for example, just 1 year, then alendronic acid would be reasonable. Denosumab is not first line, primarily because of the cost. It is reserved for patients with severe osteoporosis who need their bone mineral density to be quickly boosted, or for patients where bisphosphonates have not been successful, and can be a good option or alternative as long as it's understood that therapy cannot be stopped, or if it is stopped, then not without switching to a bisphosphonate plus close monitoring of bone mineral density and bone turnover markers thereafter. And one more thing to note is that denosumab is more effective on treatment-naive patients. So prior bisphosphonate use does blunt the effect of denosumab, but bone mineral density gains are still better in patients who have made the switch from bisphosphonates to denosumab than those who remained on bisphosphonates. And in any case, most patients are started on bisphosphonates to begin with, as that is standard first-line osteoporosis therapy. So to recap, denosumab is a monoclonal antibody which inhibits rank ligand, and thus osteoclasts and bone resorption. So is classed as an anti-resorptive. It is a second-line alternative option to bisphosphonates for patients who are either not able to have bisphosphonates or where bisphosphonates have not been effective enough for them. It is given 6 monthly as a subcutaneous injection, where it does give greater bone mineral density gains than bisphosphonates, although more data is required to determine fracture risk reduction and adverse effect incidence, including atypical fracture and osteonecrosis of the jaw. On stopping denosumab, there is a rapid return to baseline bone mineral density and a rebound phenomenon where there is hyperresorption and multiple vertebral fractures. Its main limitations currently are its costs and concerns with how to safely stop it, which currently is limited to switching to a bisphosphonate. So that brings me to the end of this video and the mini-series on anti-resorptives for osteoporosis. So next I'll be starting on the anabolic therapies for osteoporosis. I hope you found it helpful. Please check out the other videos in the osteoporosis series if you haven't already. Thank you for watching.